Coffee with Caregivers production costs are covered by a partnership with United Healthcare and the National Foster Parent Association. We receive no federal or state funding and depend on our constituents and viewers to help us achieve our goals to provide support and services that meet identified needs within our mission. We would like to welcome the viewers of Coffee with Caregivers to the family. The National Foster Parent Association offers several membership opportunities for individuals, child placing agencies, and state and local affiliates. You can join today or donate at nfpaonline.org.
Well, good morning, everybody. Welcome to Coffee with Caregivers. It's a beautiful day here where I am in Texas, and I hope you're experiencing a beautiful day where you live as well. We have a wonderful guest for us today, and so I'm going to keep my comments brief to open this episode of our program, just because of the wealth of information that you're going to be able to hear and learn from shortly. So my cup today, I thought was appropriate because of who our guest is. And so I'm going to give you a hint by saying my cup says chaos coordinator. This fits in a lot of ways. It certainly fit as a foster parent for 27 years. And it's fit in pretty much every job I've had, off and on. And it fits quite well right now on my last, October, November, it's 3 months coming up of working for the NFPA and trying to get everything done and my ducks in a row before I hit retirement. And so when I asked Dr. Jim Kagan to be our guest, I went through my cups collection and I thought this has got to be the one for today. Because this wonderful man is going to talk to us about what happens with kids and families, and how that affects their futures, and then how that affects caregivers, and certainly staff that work with those families as well, to help us better understand the children in our care, the children that join our families, some of the needs probably of their parents that will help us in reunification when we understand better the child and the child's actual diagnosis and needs. So I'm just not going to fool around anymore. I'm going to introduce Dr. Jim Kagan to you. Again, I'm so excited to have you on. I've wanted to do this for a long time, and actually had lost your email and didn't know how to get a hold of you. And then talking with our colleague, got all that again. So it's wonderful to reconnect with you, Dr. Kagan.
Well, thanks, Irene. It's a real pleasure to be here with you today. I have a cup too.
Yeah. Oh my goodness.
You can see it.
Yeah, please do not confuse your Google search with my medical degree. Right. Oh my God, that's priceless.
Please do not confuse your Google search with my medical degree.
That is priceless. Where in the world did you find that one? That's a great one.
Well, it was given to me as a birthday present a couple of years ago by a friend of mine who's a retired psychiatrist. And we both thought it was pretty funny. I was a little afraid to bring it this morning because in a way, it sounds a little condescending. And I don't mean to imply that because I have a medical degree, I know everything. Every day I'm reminded of how little I know. And I liked your comment about chaos coordinator. I often feel like that.
I'm sure you do.
Yeah. Have to be creative in this job, but I love kids. I was a pediatrician for many years before I went back to do a psychiatry residency. So now I've been practicing psychiatry for about a little over 30 years now. So I've been doing this for a long time. There are two or three things I'd like to address today. they have to do with psychiatric illness, mental, bona fide, diagnosable mental illness in children in foster care. Several studies have confirmed the fact that from 60 to 80% of children in foster care have a bona fide, diagnosable psychiatric illness. And although these diagnoses are apart from the neglect, the abuse, the trauma that most of these children have experienced, the combination of those deprivations and traumatic experience with the underlying psychiatric illness produces this chaos that we see in these children. And if you live with one of these kids, you don't only see it in the child, you experience it yourself. I experience it in the office when I'm sitting here with my little patients, and oh my God, where to even begin? It does feel a little crazy, and they can make you feel a little crazy. And from a psychological point of view, this sounds a little woo-woo, but you're not only experiencing your own chaos, you're actually experiencing the child's chaos. It's like they project that chaos into you as the caregiver, as the parent, hoping against hope that you'll know what to do with this awful, chaotic feeling that they walk around with in their heads 24/7. So I want to spend some time talking about this fact that that these kids, most of them, have a diagnosable psychiatric illness. But equally as important, as I said, is the environmental background that these children have grown up in. So there's no question that trauma and the impacts of trauma are huge, but it's not trauma alone. It's not deprivation alone. It's not abuse alone. It's that in combination with these underlying mental illnesses that I'll talk about. When kids come into the foster care system, let me back up a second. Many years ago, a very smart psychiatrist came up with an idea. He said, human beings are really complicated. And certainly doctors don't know everything by a long shot. There are several ways to look at human beings in order to understand them better and to help them better. And so he came up with a model he called the biopsychosocial model. And what this does is look at people from these three perspectives. So we all have a social life. And in the case of children in foster care, their social life encompasses neglect, abuse, trauma, and often much more. And so the social aspects of their lives need to be addressed. And that's largely why they're in foster care, to remove them from the social environment that was so harmful to them. But there's another way to look at people, and that's from a psychological perspective that has to do with the mind. How does our mind understand our experiences? And what does our mind do with that information? How does it process that information so that we can understand what we're experiencing? We adults have a hard enough time understanding this complicated life, increasingly complicated life that we live in. But imagine what it's like to be a 3-year-old or a 4-year-old who doesn't have the brain maturity or the life experience to put things together. Imagine how they understand what the world is like. It's unsafe, and they have absolutely no recourse. They are totally dependent on adults in their lives. For many of them, thank God for the school teacher, or thank God for grandma, or the neighbor lady next door. So their view of the world is pretty unique and pretty devastating, and lacks hope unless there's been a compassionate adult in their lives.
Right.
So trying to understand and make sense of that, pretty darn hard for a little child. They don't have the equipment. They don't have the mental equipment to do it. And as they get older, they're relying upon those old ways of understanding, just as we all are. I mean, we're sort of prisoners of our own, all of us are prisoners of our childhoods. So it's not so easy to shake those old paradigms, those old ways of understanding. Okay, so that's the psychological. So we've got the social aspects, the psychological aspects, and then there are the biological. And in a few minutes, I'd like to spend some more time talking about the biological.
You bet.
Which includes medical, genetic, substances, chemicals, all of those things. So we are animals. We arrive here genetically programmed by our parents to be a certain way, to look a certain way, to, in many ways, behave in certain ways, to respond in certain ways, to have certain talents, to have certain strengths, and to have certain weaknesses. There's a fascinating fact that I think about often. We often sort of blame our parents for certain inherited strengths and weaknesses. But if we go back 5 generations, so our parents, parents, their parents, we go back and back and back, it turns out that each of us has inherited genes from over 1 million different people. We are not just products of mommy and daddy.
Absolutely.
Well, yes. So there's something like 30
Dr.
or 40.
Kagan, I might just say,
Yeah.
That reminds me, we had a child join our family years ago. A little fella was in the hospital the first 6 months of his life. And he had a condition called Menkes kinky hair syndrome.
Mm-hmm.
And which was kind of the layman's terms, but Dr. Menke is the one who had discovered this. And it was so interesting because it was a phenomenon, a condition that only occurred, as far as science could tell, every 5th generation. And he had it, and nobody knew how to treat him. One hospital in San Antonio, Texas, had him for 6 months. He was terminal. Nobody lived past 18 months with that. His family went back to Mexico, so they weren't available. And so he joined our family. And he lived to be about 13 months old. But it was interesting because every day was a learning experience, not only for us as his foster parents, but for his physicians as well, because they had never, you don't treat this, right?
Yep.
And so when you're saying this 5 generations back, it just triggered our experience with this precious child.
Yes. And in psychiatry, we have diagnoses, labels, if you will, for conditions. These diagnoses are what are called phenomenological diagnoses. It's not like diabetes, where you can draw blood test and find that the blood sugar is elevated. And so then you can diagnose diabetes. Our psychiatric diagnoses, for the most part, are based upon what we observe, the child's behaviors, the child's thoughts, the child's feelings. There's a movement in medicine and in psychiatry to turn more and more towards genetics, and it's being very helpful in helping us to decide which medications are most likely to be helpful, knowing what the family history is. But my point is that human beings are so complicated. We're kidding ourselves if we think just because we have a diagnosis that explains everything. Not by a long shot. And we all have unusual aspects to ourselves, many of which may be inherited from generations back, that nobody knows and nobody's seen this before. Well, there's no kid in this family like this. Or oftentimes I'll see a child in a family who's sort of an outlier, like they drag this kid in to see me. All the other kids in the family are fine. Why is this kid having all these problems? A lot of it's genetic, but at any rate, I tend to ramble sometimes.
That's okay. But I'm sorry I interrupted you.
Oh,
but
no. That's okay.
This child just flashed into my mind so clearly, and how closely we had to work with the medical community until his passing, Yeah. And I think if I remember at the time, they did a study nationwide, and they only found 2 other infants with that condition in the whole country. It was so rare.
It rings a bell from my old pediatric days. I've never seen a case and I don't remember anything about it, but the name, it's such a peculiar name, Minky hair syndrome. Yeah. But your comment about working with medical people and other people brings me back to my point, which is that if we view people not just from one perspective, but from the social perspective, the psychological perspective, the biological perspective, if we use this biopsychosocial model, we're in a better position to understand what makes this child tick. What are all of the factors that are interacting with one another to bring this about? And maybe I could just give a brief little scenario to describe an example of what I mean. Let's say a child enters foster care with a host of behavioral problems, and it's been documented that he's not safe living with his mother. So it turns out that his mother was 15 years old when she got pregnant with him. And she had attention deficit hyperactivity disorder. And like many teenagers with that disorder, she was not doing well in school and she dropped out of school. So she didn't get much of an education. She started experimenting with drugs. She drank a lot. She smoked cigarettes a lot. She had a string of boyfriends who were not the best. And she became pregnant by one of them who had just been released from prison for committing a series of violent crimes. And she stayed with him for a couple of years after the little boy, now in foster care, was born. And this man was abusive, physically, emotionally abusive to this child. And he suffered untold trauma. And then he was removed from the home and placed into foster care. So this child is at risk for having inherited ADHD from his mother. He's at risk from being poorly nourished and poorly oxygenated during pregnancy because his mother was neglecting her own health, smoking cigarettes, which is known to interfere with growth during pregnancy. He was exposed to high levels of alcohol, which crosses the placenta into the fetal brain. He was neglected because his mother was preoccupied with her drugs and her boyfriend. He was traumatized physically, emotionally, and emotionally deprived by his mother. And now he presents at our doorstep. That's one complicated picture.
Wow.
And it's not an uncommon one at all. Where to begin? And all we see is a little boy who's unhappy and has temper tantrums and can't sit still in school. Well, does he have fetal alcohol syndrome? Does he have ADHD? Is he just acting out behaviors to show us what he's been through? Where do we even begin? And so this is how this biopsychosocial model can be put to use to help understand what makes kids tick. And so it requires, just as you said, coordination of care.
It does.
So when a child enters foster care, they get a social intervention immediately. They're removed from the home and put into a safe home. Wonderful. But then what? If they're lucky and the resources are present, maybe they get to, if this is a little kid, maybe they get to do play therapy. If it's an older child, maybe the local mental health center has a therapist who can meet with the child weekly and do some talk therapy. And that would be wonderful. And maybe they can provide, maybe the counselor or therapist can provide the foster family with some guidance, some behavioral interventions that they can use to help guide this child. And if this kid is really, really, really lucky, maybe you'll get to see a doctor, that is a medical doctor, a physician, a pediatrician, maybe even if he's really, really lucky, a psychiatrist. And together, all of these people, the social worker, the psychologist, the pediatrician, the psychiatrist can work together to make the correct diagnoses and then come up with the most effective integrated treatment plan.
All of our years in fostering, most of the children that we had join our family were able to receive weekly mental health counseling. We were very fortunate, but we were strong advocates. So
I'm sure you were.
And
knowing you, I'm sure you were.
Got to see their psychiatrists as well. And it didn't take me long in the process of fostering to know that I needed time with that therapist too. And so I would always, when I had a new child join the family, was setting up therapy, I'd always ask the therapist, would you prefer, and I wouldn't say, do you, I'd say, would you prefer spending 10 minutes with me at the beginning before you see the child, or 10 minutes with me at the end? So we can discuss what's been going on or what I need to do next week, that kind of thing. And at first I actually got a little bit of, well, I don't really do that, but I was pretty darned insistent, and didn't take long. And that was the norm for us. And I just have to say that was probably one of the best advocate moves I've made in my entire life into having a better understanding of what was happening. I mean, in therapy, the general goals, those kinds of things, me reporting what had been going on during the week, finding out what are the, recommendations for this week moving forward, that kind of thing. And I don't know if caregivers feel like they have the right to ask for that.
I certainly agree with you, and I strongly encourage foster parents to not be too shy. Speak up. one of my heroes of all time is named David Winnicott. He was like me. He was a pediatrician who then became a psychiatrist. He's British, and he's very well known. And he had this saying: "There's no such thing as a child, only a child and a mother. That is a unit. You can't separate the child out of that."
Yeah.
And it's so true. Children do not exist alone.
No.
They cannot survive alone. And they need more than just food and shelter and clothing, obviously.
That's for sure.
Yeah. The magic that goes on between a parent and a child is just essential for normal growth and development. And that's one of the things that so many kids in foster care are removed from. They're removed from their birth parents, who have not been adequate parents.
Mm-hmm.
Nevertheless, this child is receiving something absolutely essential from those parents.
Right.
It's just such a dilemma what to do. And
yeah, and just think what that child experiences then if they are separated from their parent or parents and go into foster care, whether it be family foster care, the kind of the traditional way we know it, or kinship care even, and that doesn't last very long. And then they have to move someplace else, and then they have to move someplace else, and they don't have any consistency in that important caregiving role that provides so much of the emotional well-being to these kids. I mean,
Right.
It's heartbreaking to me at what we do sometimes as a system for various reasons of how we move kids indiscriminately sometimes and not really stop to think about what that's doing to that child. We certainly don't prepare the children for it.
No, they don't. And how could you? One thing that you can do is right from the get-go, let the child know that he or she's not going to be with us forever. But
yeah, I mean,
how reassuring is that? This really came home to me a few weeks ago. I'm taking care of a boy, young man. He's 14, 15 now, in foster care. He's been in his current foster home for a couple of years, and he's made great strides. This boy has got lots of problems. And working with this family, working with me, working with the social worker who's in charge of his case, and working with his family physician. All of us meet regularly on Zoom.
Wow.
Every
Wonderful.
2-3 months, we all get together and have a meeting. So this kid has done really well. I was looking at some websites recently on adoption, and up pops a picture of my patient. And all of a sudden it hit me right between the eyes. This kid is being advertised for adoption. Obviously, this is not a permanent placement. And I was just sort of going along feeling like, oh, he's doing so well in this home. Isn't this great? He'll grow up and these will be his parents. No, they won't be his parents. Somebody else will be his parents. And when I met with the family the other day, they said that they took him to visit one of their former foster children who's now in another foster home. And he became very quiet and kind of withdrawn and needy when he realized that, oh, this is going to be my fate too.
Right. Wow.
Yeah.
Poignant.
I don't have an answer for that, but
I know.
Yeah. Well, so this biopsychosocial thing. So a few years ago, my good friend and your good friend, Rick Delaney, psychologist, he and I wrote a book
Yes.
called A 3D View of Foster Kinship and Adopted Children, in which we talk about using this biopsychosocial model. And so that's available if people want to look into that.
Right.
Now, I don't know how we're doing for time. If you want, I could go into talk a little
Yeah,
bit about psychiatric
we're,
illness? Or?
yes, sir. We're kind of right at the 30-minute mark. So if you want to continue, that would be great.
Okay. Well, a lot of times in my practice of psychiatry, child psychiatry, I often find it helpful to explain mostly to the parents if the children are too young, but if the kids are old enough for them to try to explain a little bit about how the brain works. Like what causes depression? What causes attention deficit disorder? What causes anxiety? And so I'll give you a little 5-minute canned speech that I've given many, many times before. On, well, how does the brain work? Like, obviously, it's vastly complicated. So this model I'm going to describe is pretty simple, but I think it helps to understand things. So the adult human brain is filled with about 40 billion nerve cells called neurons. So children have proportionately fewer, but still it's at least a billion in a young child. So of course, the whole body is made up of cells, and different organs have different kinds of cells, and the nervous system has neurons or nerve cells. And nerve cells are very unique among cells in general in at least a couple of ways. One is that they actually can conduct microvolts of electricity along their surfaces. And they have these little fibers coming off of the cell body. So if you think of like a round cell with a nucleus in the middle, going back to biology in high school, there's a cell membrane, there's the cytoplasm and the nucleus that has all the genes in it. And then coming off the cell membrane are these fibers, lots of fibers. And even though the cell is microscopically tiny, sometimes the fibers can be inches or even a foot or two long coming off of a single cell. And those fibers, called axons, also conduct microvolts of electricity. So if you can picture a billion cells,
wow,
and their axons, where the axons connect, let me get out of the way. I use my fingers.
Yeah.
Where they connect, you've created a little electrical circuit because the electrons travel along the surface of one, cross the gap, travel down the next one. And so if you string together a few 100,000 of these cells, you have an electrical circuit, a complicated electrical circuit that's capable of doing all the amazing things that our brains do. It turns out that the average neuron can connect in this way to an average of 10,000 other neurons. So in an adult brain, you got 40 billion nerve cells. Each one can connect to 10,000 others. So the degree of complexity is
amazing.
Yes, but that helps to explain. I mean, it's like in a way, it's like a computer, and it's capable of doing incredible things. We all know our brains are absolutely incredible. These circuits, these electrical circuits, tend to cluster together into like cables, and there are anatomical areas within the brain where they're clustered together, and you could think of those areas as being like little software programs. So there's an area in the back of the brain that has to do with vision and seeing. And there's an area on the top of the brain that has to do with thinking. And there's an area on the side that has to do with hearing. There's an area that processes numbers. And there's an area that processes speech. There's an area that keeps us breathing. There's an area that keeps our heart beating. It turns out that about 90% of these circuits function automatically, that is, without requiring any conscious thought on our part. 90% of what the brain does is genetically programmed to take care of business. It does what it's programmed to do. Keeps us breathing, keeps our heart beating, digests our food. So that's my quick little background speech. If we have time, I can touch briefly on a couple of 2-3 things. Let's say depression. Okay, let's say depression. So depression is a psychiatric diagnosis. As I said, it's phenomenological. We make the diagnosis of depression based upon the following symptoms. The person's sleep is disrupted. The person is tired all the time. The person has lost their appetite. Their mood is low, depressed, unhappy, sad. They cry. They don't feel like they can think as clearly. They just don't feel as smart as they used to be. They may have suicidal thoughts. They may feel that life is hopeless and worthless. If we get 5 or 6 of these symptoms, we say that person meets the diagnostic criteria for depression. But what's going on in the brain? Mm-hmm. In the case of depression, there are problems in the circuits having to do with sleep, energy, appetite, mood, thinking, so forth. And the problem is this, and we're going to have to go back to the basic science. Remember I said that the tips of the neurons come together and connect. Turns out they don't actually touch. There's a gap. And molecules called neurotransmitter molecules move back and forth. They make the connection. Inside every cell in the body are about 40,000 genes. And there's a gene that's specific for making neurotransmitters for every circuit in the brain. So it turns out that there's a neurotransmitter called serotonin. That's the primary neurotransmitter in the circuits subserving these symptoms: sleep, energy, appetite, mood, so forth. So these people have presumably inherited a slightly defective gene. It doesn't make quite enough serotonin in those circuits. So here's where I make kids laugh. I say, I've inherited a gene that doesn't make enough hair on top of my head. We've all inherited lots of genes that don't work perfectly. Maybe it's good enough, but it's not perfect. You've inherited a gene that doesn't make enough serotonin in these circuits, and that's why you have the symptoms of depression. But it turns out that there's a medicine you can take that'll increase the amount of serotonin. And then we prescribe an antidepressant. And lo and behold, after 2 or 3 weeks, the serotonin level rises and the symptoms go away.
Yeah.
Now, that doesn't mean that the child isn't also depressed because he's been deprived, traumatized, neglected, he's short, isn't too cute, isn't too good at baseball, all these other things. Yes, absolutely. It's all of these things. But if we don't have an opportunity to correct that serotonin deficiency, there's essentially nothing you can do to raise the serotonin level. All the love in the world is not going to raise the serotonin level. It's not. So we have to have an opportunity to make this diagnosis.
Right.
Same thing occurs in anxiety, in attention deficit disorder. It's basically the same kind of mechanism. The child has inherited a gene that doesn't make quite enough of a certain chemical, and therefore the circuits that are responsible for the symptoms are not functioning normally. I hate to say nothing, it's all or nothing, but if the child doesn't get the right medicine, those symptoms are not going to go away. I'm sorry.
Right. No matter how much love and attention you give them, it's not going to work. Right.
It might help, but it's not going to fix the problem. Mm-hmm. It's not going to fix the problem, and the problem needs to be fixed. And that child deserves to have that problem fixed just as much as every child deserves to have that fixed, as long as it's within our ability to do that. So it's a systemic problem for sure. It's a resource problem,
We hear often, that children in foster care are over-medicated, particularly with psychiatric drugs. And so I just really appreciate your description of how the brain works, and why some of these medications truly are like a lifeline for these kids to feeling some normalcy. And the other thing you've talked about, I just there's so much involved in what makes a child who they are.
Yeah.
And it seems like before we came on the air, we kind of talked a little bit about how everything it seems to be related to trauma experiences now. And we've almost forgotten that there's all these other pieces, the biological, the psychological, and the social, that are still there, just like they've been forever. And those of us that fostered some years ago, that's what we dealt with. We didn't even talk trauma much, and it's kind of like trauma now trumps everything. So what you've talked about to me is just so important for all of our constituents to hear and to better understand that we have to look at all of those dynamics when we're looking at how to help the children.
We do. So that's why Rick Delaney, again, and I developed, after we wrote the book, we thought, well, we need to make some kind of assessment tool accessible to people, because there just aren't enough of all of us to go around. So we have developed a little online tool called Adapt.
Right.
And we hope that people will find it useful. It takes the biopsychosocial approach to understanding kids, and the parent just goes online and answers all the questions, and then they get a little report that outlines what the algorithm has uncovered and what some next steps might be to get help for the child.
That's awesome.
So we hope that people will find it helpful.
Yeah. Would you supply the web address for that tool to us or to me? And
Sure.
Then if folks are interested, they can use our info@nfpaonline.org email address and let me know that that's something they're interested in, and we can share that with them if that's okay with you.
I would be delighted. You bet.
Awesome.
You bet.
All right. Well, Dr. Kagan, I hate to even say that our time is about up, but it is. And
going by for me.
You have provided a wealth of information to our constituents, and I so much appreciate that. I appreciate your tenacity in what you've been doing all these years, and the fight of chaos often on a daily basis, I'm sure. But your wisdom is profound, and we really appreciate the opportunity to share that with everyone. I just want to remind folks out there, because I did get this question this week. Well, I missed it. What do I do? An episode. Well, if you do, it's somewhere on Facebook, right? On our Facebook page. But you can also go to the NFPA's website, and all of these episodes are archived there. And then you can also go to our YouTube channel, because they're all there as well. So lots of opportunity for folks if you missed it. And certainly if you feel like the information you received today or on other Coffee with Caregiver episodes is to share with those that you think it will help, because they're out there for everybody. They don't have to be available on Tuesday morning at 10 a.m. Central in order to get this wonderful information. So again, Dr. Kagan, thank you so much. And I hope we can maybe do this again. Maybe not me, because I'll be gone, but if this continues into 2022, whoever the host would be, I'm going to leave your name on a list with a big star beside it. Okay?
I'd be happy to. You bet.
All right. Thank you so much.
My pleasure.
Bye, everybody.
Thanks for having me.
This episode is brought to you in partnership with our friends at United Healthcare. For more information about United Healthcare, please visit www.uhc.com.